This conference will now be recorded.
పీపీటీకి ఇది అడ్డు వస్తుంది మా పోయినసారి అతను పెట్టింది అట్లా అడ్డు రాకుండా చూడరా. అదే అది అడ్డు రాకుండా. స్టార్ట్ చేసేసాను. హలో, గుడ్ ఆఫ్టర్నూన్ ఎవ్రీవన్. సో టుడే విల్ కంటిన్యూ ది abdominal aortic aneurysms. So today, how will you manage the ruptured aneurysm? So patients who survive to present to the hospital with a ruptured abdominal aortic may range from a stable condition to a circulatory collapse condition. So abdominal aortic aneurysms can rupture anteriorly into the peritoneal cavity. These are the least percent, 20%. Majority of the patients, so they rupture posterolaterally into the retroperitoneal space. That is approximately 80% of the cases. So less than 50% of patients with rupture who survive can reach the hospital. So anterior rupture results in free bleeding into the peritoneal cavity. So very few patients reach hospital alive. So posterior rupture on the other hand produces a retroperitoneal hematoma. So often a brief period ensues when a combination of moderate hypotension and the resistance of the retroperitoneal tissues, they will arrest the further hemorrhage and may allow the transport to the patient. So the patient may remain conscious but may be in a severe pain. If no surgical intervention is performed, so death is virtually inevitable. So operative mortality is around 50% and the overall combined mortality, that is both community based and hospital, is around 80 to 90%. So ruptured abdominal aortic aneurysm, it is in a surgical emergency. So it should be suspected in a patient with the triad of severe abdominal back pain or abdominal pain or back pain associated with hypotension and a pulsatile abdominal mass, which is visible in the epigastric mass, supraumbilical region. So CT scanning should be used to establish the diagnosis and to determine whether an endovascular repair is possible or not. So good venous access is needed for resuscitation, that is infusion of, because patient may be in a shock. So infusion of saline or volume expanding fluids. So but the systolic blood pressure should not be raised any further more due to, because it's to maintain the consciousness of the patient and permit the cardiac perfusion. So it should be less than 100 millimeters of mercury diastolic pressure. So many surgeons now adopt a policy of permissive hypotension, so where fluids are withheld if the patient is conscious. So cerebral perfusion is therefore adequate in order to avoid the provoking further uncontrolled hemorrhage. So in the operating room, consideration should be given to the what is the type of method and timing of the anesthesia. So endovascular repair may be performed initially or in its entirety under local anesthesia. So because immediate step is to control the hemorrhage or bleeding. So when open repair and general anesthesia are required, then it is prudent to complete the positioning, sterile preparation and draping of the field before induction of the anesthesia. So in treating a ruptured aneurysm, a supraciliac control clamp should exactly facilitate the resuscitation and provide a measure of hemodynamic stability. So a formal protocol for resuscitative endovascular balloon occlusion of the aorta has been developed and can be of great utility in the unstable patients with ruptured aneurysms as well as other forms of hemorrhagic shock. So this balloon may be placed percutaneously to establish the proximal control in anticipation of the open surgical method or any endovascular repair. So how will you post-operate management? So in the immediate postoperative period, patients are typically admitted in a ICU with continuous cardiopulmonary monitoring. So adequate first pain control should be done, then appropriate resuscitation, adequate oxygenation and heart rate control, because already patient in a hypovolemic shock, so there will be reflex tachycardia will be there. So heart rate control also serves to minimize the risk of postoperative myocardial infarction. So epidural anesthesia and patient controlled analgesia are both excellent options for postoperative pain management, because epidural anesthesia we can top up the that is top of the painkiller medicine. Like, nowadays we are giving the tramadol injection in a epidural kit. So after 24 hours or 12 to 24 hours after surgery, depending upon the patient pain, so we can remove the epidural kit. So an epidural anesthesia may actually decrease the post-operative complication, especially post-operative pain. So the use of appropriate prophylaxis for deep vein thrombosis should be done. So attention to, you should mobilize the patient early, and nutrition of the patient is also important for better recovery. So, although the late events after open surgical repair are relatively rare, so the overall surveillance is a typical to detect the complications such as the formation of anastomotic or para-anastomotic aneurysms, so which accounts for 20% of the time at 15 years after the repair. So all these complications will may occur in 20% of the surgical processes patients at 15 years after repair, not at the earlier period. So the authors typically image the patients with the CT initially, then at 5-year intervals. So you should follow the patient, because these are the complications which occur after 15 years of the repair. So for every follow-up, you should ask the patient to get the CT and then 5-yearly intervals after the repair. So ultrasound may also be used for surveillance, but is operator dependent, because it depends upon the surgeon and lacks the sensitivity of CT for detecting the anastomotic or para-anastomotic changes. So better choice of investigation, choice of screening is CT only. So ruptured aneurysm may pose a significant challenge in the especially post-operative period, whether it is approached in an open procedure and an endovascular fashion. So the incidence of serious complications such as especially colon ischemia, renal failure, spinal cord infarction is significantly higher than after this is the after elective repair, and is also associated with the increased mortality when it is compared with the emergency techniques. So surgeons must remain vigilant as colon ischemia may be manifested subtly and must have a low threshold for sigmoidoscopy if it is suspected. So have a look at a endovascular repair. So in 2006, the Agency for Healthcare Research and Quality published a comparison between the endovascular aortic repair, aneurysmal repair and open surgical repair of the abdominal aortic aneurysm, that concluded that endovascular procedure has shorter length of stay, lower 30-day morbidity and mortality but does not improve the quality of life beyond 3 months or survival beyond 2 years. So there is no benefit of endovascular procedure in case of quality of life and the survival when compared to the surgical repair. So these advantages, although limited, have been sufficient to make the endovascular more frequently performed in recent years than open surgical aneurysms with suitable anatomy. So for shorter length of the stay and lower 30-day morbidity and mortality. So these are the advantages over the open surgical repair. So early morbidity and mortality, that is 0.5 to 1.54%, that is the 3 to 4.8% is lower with the endovascular. So this is the open surgical procedure percentage and this is the endovascular procedure. So there is overall a higher rate of re-intervention after endovascular than after open aneurysmal repair. So, and after 2 to 3 years, no significant difference in the overall mortality rate. So, the majority of available devices are modular bifurcated grafts consisting of an aortic main body to be used with a variable number of iliac and the or proximal aortic extension components. So, these are the endovascular process after termed as a stent graft is usually made of the three separate parts, a main body and the two limbs which are enclosed in a separate delivery catheter. So sometimes they will have only two pieces. So a main body with the same side limb attached and a separate contralateral limb. So first diagram is with two limbs along with the body, whereas the second diagram shows that separate contralateral limb processes. So the processes is made from dacron or polytetrapropyl fluoroethylene with integral metallic stents for the support. So the delivery catheter is inserted into the aneurysmal sac and the stent graft employed by withdrawal of the delivery system. So most systems now have hooks or bobs to anchor the processes in the aortic wall in place, and some surgeons inflate a molding balloon catheter in the stent graft to ensure the hooks and bobs are engaged and a good seal is obtained. So although the top edge of the fabric of the stent graft has to be employed below the renal arteries, that is the most common origin of the abdominal aortic aneurysm, infrarenal fixation. So some systems have additional bare metal stents at the proximal end of the main body that lie across the renal arteries to give better support and the fixation, that is suprarenal fixation. So blood flows between the metal struts of the stent into the renal arteries. So success is dependent on the good seal between the stent graft and the proximal and distal landing zones in the aorta and the iliac arteries. So failure to achieve a good seal results in an endoleak. So that means that the aneurysm is not excluded from the circulation and may still expand and land up in a rupture. So patients who undergo endovascular procedures may require lifelong follow-up and surveillance with duplex or CT scans to detect the endoleak, which is the dreaded complication. So disconnection of the components and migration of the stent graft all are other which may predispose to the late rupture. So it is recommended that the contrast CT surveillance be conducted at 1 month, 6 months and 12 months after graft implantation and then yearly thereafter whenever after endovascular procedure done. So the patient may need a long follow-up. So early peri-procedural complications include the endoleak access-related complications which occur up to 3% of cases, which may include the hematoma, they may cause pseudoaneurysm, arterial occlusion or arterial dissection, and iliac artery rupture or transection. So peripheral embolization can occur, renal insufficiency or local wound complications, inadvertent renal or hypogastric artery occlusions, and rare occurrences such as colonic or spine ischemia. So all these are the early endovascular complications. So late complications which may include the rupture which occurs rarely but at a higher rate than after when compared to the open procedures, and graft limb occlusion, endoleak or sac enlargement, and graft infection. These are all the late complications. So we will move on to the other small topic, suture materials.